So we have a patient that was admitted for ammonia, currently in respiratory distress of 30 to 40 breaths per minute. The physician is intubating him. He's 5 feet 4 inches tall. He has 120 pack smoking history and a COPD and CHF. So the settings we're going to want this patient on is pressure control, which I already have it on pressure control in the settings I don't want. So we're going to start out at 100% FiO2 and kind of wean that as we go. We have pressure control 20, 1 second eye time, 14 respirations, a PEEP of 5, and a slope of 0.2. So we have the vent setup complete. We have the tubing all hooked up. We have it plugged into the wall with air and oxygen. So our vent setup is complete. So we are going to do our assessment and documentation. So we come into the room and we are going to log onto our computer and pull up our flow sheet. So this is an example of another patient's flow sheet. So what we want to do here on the side are the ventilator settings. So do these settings match this settings? Pretty much we're just referring to make sure that they are okay. These ventilator patient values is the current patient values. We want to document these before we perform any suctioning or treatments because this is what they're currently at, and after we do those treatments it'll probably alter them. So we will take these values here and just translate it over to our flow sheet. We can double check our alarms. So we have our alarms, and do we have the alarm set on what we want? So they look okay. So we'll just double check the alarms are set correctly. Do we have a humidifier in place? Which yes we do, right here. The temperature, if we had that hooked up, it'll give us the temp right there. And suctioning, so yes we are going to suction this time. So the goal here is we have inline suctioning already hooked up. We can hook this up to the banister over there on the wall, or usually it's probably on the same side as the ventilator. So we have that hooked up, we have it on the correct settings, and so we are ready to do the goal here is to, once we are suctioning them, that we want to bring back that plastic so it's a nice kind of push in and pull back. It's hard to kind of do with one hand, so that if we do have it all bunched up, we're not actually getting that little bit of tubing that needs to go down into the patient. So it's good to have good practice of pulling that back to prevent that resistance. So let's say we're going down and we either hit resistance or it's as far as we can go. We can, once if we hit resistance, we can go back up a little bit, and then we're able to press that in, and kind of nice and slow. You do have 15 seconds. We will suction that out. We want to make sure that this black piece here is all the way back, otherwise it'll cause resistance here in the tube. The alarm. So while we're pulling that out, we are able to see what color sputum is coming up, clear, yellow, whatever color that may be. It's not liking that. So we can document that. We will do a patient assessment, listen to breath and lung sounds, see if they've improved or worsened. Let's say they're still sounding pretty coarse. Doctor orders a duo-neb treatment. So after verifying the doctor's order and the patient, we use a mesh inline neb. So we're able to put the medication in there. We can switch this over to aerosol so we don't have to take this out. And then we turn this on and it does it inline. So every time the machine gives the patient a breath, they are receiving that medication. Let's say the patient has a at-home Symbicort inhaler that they use, and the doctor would just like to have the same order. So we can take the canister, we can put it in line here, and then the goal here is to deliver the medication simultaneously with either the breaths that are giving, or if you need to give a breath hold. So we're going to disperse, do a breath hold, and release. Wait 30 seconds, disperse, breath hold. There we go. So we're mimicking what we would do with a normal patient delivering an MDI. We also want to take this time to make sure we're watching our monitor, our O2 stats, our pulse, if it's rising or falling, if there's a blood pressure, if any of those things alter, we need to make sure we let the nurse or physician know, because that's some pretty important things. While we're doing our patient assessment, listening to breath and lung sounds, we want to make sure the chest is bilaterally rising and falling. We want to check the ET tube to make sure it didn't get pushed in, pulled out. So we will verify that it's at the correct length, let's say 26. And so we just want to verify that that's at the correct place. We might want to kind of move that around on the lips so that we prevent any skin breakdown. We always want to make sure we're telling what the patient what we're doing. When we're suctioning, when we go all the way down, before we start suctioning, tell the patient we're going to make them cough as we suction out so that they're prepared for that. They might not fully be with it or sedated, so it's just good reassurance to let them know that if they are listening to you, that they have an idea of what you are doing. So then our flow sheet automatically saves. Everything looks good, our patient is stable, and we are finished with our check, setup, and suctioning and med delivery.